A very warm morning to all and all present here, respected professor, my friends. I'm Manshubas, roll number 46, and these are my friends Ishana, roll number 47, Ishita, roll number 48, Izhar, roll number 49, and Zahira, roll number 50. And we are here to present the topic disorders of carbohydrate and metabolism. And the very first topic is the carbohydrate metabolism, where the differentiation is there. Carbohydrate metabolism is the sum of all the chemical process in the body that involves digestion, absorption, transport, storage, and the utilization of carbohydrate to produce energy and maintain the normal body functions. It includes processes such as digestion and absorption, carbohydrates, glycolysis, glycogenesis, glyconeogenesis, and gluconeogenesis. This process helps regulate blood glucose level and provide energy for cell. Now, moving to the next topic is the importance of glucose. The importance of glucose, the primary source of energy, glucose is the body's main fuel and provide energy for the cellular activities essential for brain function. The brain relies heavily on the glucose as its primary energy source, supports muscle activity. Muscles use glucose and during the exercise and physical work, maintains blood sugar level. A constant supply of glucose is necessary for the normal body functioning. Stored for future uses, excess glucose is converted into glycogen and stored in the liver and muscles as well. Now, we will see the overview on the glycolysis and glycogenesis. Now, coming to the glycolysis, these are the steps of the glycolysis where glucose is ultimately converted to the pyruvate. In the very first step, glucose converts to glucose 6 phosphate in the presence of hexokinase, where 1 ATP is utilized, and the glucose 6 phosphate converts to fructose 6 phosphate in the presence of isomerase enzyme. This fructose 6 phosphate converts to fructose 1 6 bisphosphate in the presence of phosphofructokinase, where one more ATP is utilized. Now, fructose 1,6-bisphosphate converts to glyceraldehyde 3-phosphate in the presence of aldolase, and this glyceraldehyde 3-phosphate converts to the 1,3-bisphosphoglyceride in the presence of glyceraldehyde 3-phosphate dehydrogenase, where NAD plus inorganic phosphate converts to NADH plus H plus ion. Now, moving to the next step. This 1,3-bisphosphoglycerate converts to 3-phosphoglycerate in the presence of phosphoglycerate mutase. And the next step is the 2-phosphoglycerate further converts to the phosphoenol pyruvate in the presence of enolase enzyme. Now this phosphoenol pyruvate is converts to pyruvate in the presence of pyruvate kinase, and ultimately it goes to the further steps like acetyl coenzyme. Now, next is the glycogenesis, where glucose is converted to glycogen, and these are the overview of the glycogenesis, where glucose converts to glucose 6 phosphate in the presence of hexokinase, where ATP is utilized in the very first step. Now, glucose 6 phosphate further converts to glucose 1 phosphate in the presence of mutase enzyme. Now, this glucose 1 phosphate converts to UDP glucose in the presence of UDP glucose pyrophosphorylase, where UDP is converts to inorganic phosphate. Now, this UDP glucose is important for the conversion of multiple glucose unit into the single glycogen unit with the help of branching enzymes. So, this was the overview about the glycogenesis. Now, coming to the next topic about the mechanism of glycogenolysis. Here we will see the overview about this. The glycogen, in here, the glycogen converts to glucose 1 phosphate, uh, where, uh, where the debranching enzyme like glucan transferase and 1,6-glucosidase. Now this glucose 1 phosphate converts to glucose 6 phosphate in the presence of phosphoglucomutase. Now this glucose 6 phosphate is further converted to the glucose, where this glucose is stored in the liver ultimately. Now, coming to the second last step, glucose 6 phosphate. This converts to the muscle. This glucose 6 phosphate is stored in the muscle because there is the absence of glucose 6 phosphatase in the muscle. Now, I would like to hand over this further topic to the Shakna. She will continue from here.
Good morning. I will continue from disorders of carbohydrate digestion and absorption. So basically, there can be problem and disorders occurring due to malabsorption or maldigestion of carbohydrate, or maybe due to intestinal transport mechanism problems. So due to this, many disorders can occur. A few examples are lactose intolerance, sucrase isomaltase deficiency, and glucose galactose malabsorption. Moving on to these disorders, first I will explain lactose intolerance. Lactose intolerance is a disorder which is caused due to the deficiency of lactase enzyme. This enzyme is responsible for the digestion of lactose, which is milk sugar. Different causes responsible for these are primary lactase deficiency, secondary lactase deficiency due to intestinal diseases, and congenital lactase deficiency. Different clinical features are bloating, diarrhea, abdominal cramps, flatulence, and etc. Moving on to the next disorder, that is sucrase isomaltase deficiency. This deficiency occurs due to the deficiency of enzymes sucrase and isomaltase. Sucrase enzyme is required for the breakdown of sucrose into glucose and fructose. So when sucrase is deficient, then sucrose cannot be broken down and that gets accumulated in intestines, which further is subjected to bacterial fermentation. Different type of clinical features visible here are abdominal bloating and distension, excessive gas, that is flatulence, abdominal cramps or pain, nausea, and failure to thrive. I will now pass on the mic to Ishita.
Continuing with disorders of monosaccharide metabolism, these are the metabolic diseases that are caused by deficiencies of the enzymes involved in the metabolism of galactose or fructose. For example, galactosemia. Galactosemia is an inherited disorder characterized by the inability to properly metabolize galactose due to deficiency of an enzyme called galactose 1-phosphate uridyl transferase, which causes accumulation of galactose 1-phosphate and galactidone. The gross clinical features of these diseases: vomiting after milk feeding, failure to thrive, jaundice, and hepatomegaly. The next disorder is essential fructosuria, which is also an inherited disorder of fructose metabolism that is caused by deficiency of an enzyme called fructokinase. The reaction impaired is this one, where fructose is not converted to fructose 1-phosphate. So fructose is accumulated in the blood and is excreted in urine. In this disease, there are no gross symptoms observed because fructose can still be metabolized through alternative pathways, mainly by hexokinase, and hence toxic substances do not accumulate. Thank you. I will be followed by Izhar.
Good morning, everyone. So, disorders of monosaccharide metabolism. Metabolism disease caused by deficiency of enzymes involved in the metabolism galactose or fructose. Galactosemia. The main definition of galactosemia: it is an inherited disorder characterized by the inability to properly metabolize galactose due to the deficiency of enzyme galactose 1-phosphate, which causes accumulation of disorders of blood glucose regulation of type 1 diabetes mellitus. It is mainly caused by autoimmune destruction of pancreatic B cells, absolute insulin deficiency. The clinical features are polyuria, polydipsia, and polyphagia, weight loss, and fatigue. Type 2 diabetes mellitus is mainly caused by insulin resistance and relative insulin deficiency. And clinical feature is polyuria, polydipsia, recurrent infection, and slow wound heal. So, glycogen storage disorders. GSD are a group of inherited metabolic disease which are mainly caused by deficiency or dysfunction of enzymes which are involved in synthesis or breakdown of glycogen, and as a result, glycogen accumulation in abnormal amount continues in various parts of the body like liver, muscle, and kidney and heart. These GSDs are inherited in an autosomal recessive manner, which lead to impaired glucose homeostasis causing symptoms such as hypoglycemia, hepatomegaly, muscle weakness, and excessive tolerance and growth retardation. These are mainly classified into different types based on the specific enzyme defect and then organ primarily involved in it. So the types are type 1, von Willebrand disease, and the enzyme deficiency is glucose 6-phosphate. The main features are severe fasting, hypoglycemia, hepatomegaly, and lactic acidosis. Type 2 is POM disease, acid alpha glucosidase, and the main feature are cardiomyopathy and muscle weakness. Type 3 is Cori disease, debranching enzyme, hepatomegaly, and hypoglycemia. Type 4 is Anderson disease, enzyme deficiency is branching enzyme, and the main feature is liver cirrhosis and failure to liver. Type 4 is myocardial disease, and the enzyme deficiency is muscle glycogen phosphorylase, and main feature is excessive tolerance and muscle cramps. Type C is Hirsch disease, the enzyme deficiency is liver glycogen phosphorylase, and the main feature is mild hypoglycemia and hepatomegaly. And I'm going to pass on mic to my friend Zaira.
Good morning, everyone. So, diagnosis. The diagnosis of carbohydrate metabolism disorders is based on clinical findings and laboratory investigations. So, at first, blood glucose estimation, then next, blood glucose, random blood glucose, and postprandial blood glucose. Next, urine tests. Presence glucose in urine, which is glucosuria. Presence ketone bodies in urine, which is ketonuria. Next, tissue biopsy, which next liver and muscle biopsy for glycogen storage disease. Biochemical tests, blood lactate levels, lipid profiles. Management depends on specific disorders and improve quality of life. At first, dietary management. Balanced diet with appropriate carbohydrate intake, high fiber diet, and control carbohydrate intake in diabetes mellitus. Then next, medical treatment, insulin therapy for type 1 diabetes and some cases of type 2 diabetes. Oral hypoglycemia, drugs for type 2 diabetes mellitus. Next, monitoring and follow-up, regular monitoring of blood glucose levels, assessment of growth and development in children. Lifestyle modifications, regular physical activity, weight management, and avoidance of prolonged fastings. Prevention of complications, early diagnosis through newborn screening programs. And the last one is conclusion. So disorders of carbohydrate metabolism comprise a diverse. Thank you.
Good morning, everyone. I'm Japneet Kaur, and along with me, I have Jyotishika Roy, Kavya Pal, and Jaya Roy. Today, we will be speaking on conjugated hyperbilirubinemia. The topics that we will cover are bilirubin metabolism, conjugated hyperbilirubinemia, causes, pathophysiology, clinical features, signs of examination, diagnostic tests, management and treatment, prevention and conclusion. Bilirubin is a yellow pigment produced during the normal breakdown of red blood cells. Normally, the liver processes bilirubin and excretes it in the bile. When this process is impaired or overwhelmed, bilirubin accumulates in the bloodstream. Hyperbilirubinemia is the medical term for abnormally elevated bilirubin in the blood. In simple words, hyperbilirubinemia means excess bilirubin in the blood. The total serum bilirubin level ranges from 0.2 to 1.2 mg per dl. Hyperbilirubinemia occurs when the total serum bilirubin level exceeds 1.2 mg per dl. Clinically, visible jaundice usually appears when bilirubin levels rise above 2 to 3 mg per dl. In subclinical jaundice, serum bilirubin is elevated but less than about 2 to 3 mg per dl. Now I will be speaking about the important enzymes. Three important enzymes that are involved in bilirubin metabolism are heme oxygenase that converts heme into biliverdin, biliverdin reductase converts biliverdin into bilirubin, UGT1A1 converts unconjugated bilirubin into conjugated bilirubin. Now, I hand over the topic to Jyotish.
I'm roll number 53. Thank you, Japneet. So, let us now understand the complete pathway of bilirubin metabolism. So, we know that the average lifespan of RBC is 120 days, and after 120 days, these senescent RBCs they reach the organs like liver and spleen, the graveyard of RBC. So, after reaching these organs, they contain some macrophages, and they will split this hemoglobin into two portions, that is heme and globin. This globin will then convert into amino acids, and they will be utilized by the body. And this heme portion will be converted into iron and biliverdin, catalyzed by the enzyme heme oxygenase. Now, this bilirubin is then converted into a yellow substance, that is bilirubin, and catalyzed by the enzyme biliverdin reductase. This bilirubin form is in the unconjugated or indirect version, which is water insoluble. So it has to reach the liver in presence of the transporter molecule, that is albumin. Now, after reaching the liver, it will bind with glucuronic acid in presence of UDP glucuronyl transferase, and it will convert into its conjugated or direct version, which is water soluble. So, now this conjugated bilirubin will transport through the biliary channel to the duodenum. From duodenum, it will transport to the colon of large intestine. Now, this colon, it will contain some microorganisms, and it will convert this bilirubin into stercobilinogen and urobilinogen. Most of it will be excreted in the form of feces as stercobilin, and the stercobilin is responsible for the brown coloration of the feces. 10 to 15% of it will be absorbed by the blood. Some portion will be recycled back to the liver, which is known as the interhepatic circulation. Some of the reabsorbed compound will reach to the kidney, and it will be excreted in the form of urine as urobilin. Now, this urobilin is responsible for the yellow coloration of the urine. This pathway is extremely important, and deprivation or disruption at any stage can lead to jaundice and hyperbilirubinemia. So I will now hand over to Kavya.
Moving on with the types of hyperbilirubinemia, there are two types: unconjugated, which is also known as indirect, and conjugated, which is also known as direct. Unconjugated hyperbilirubinemia is caused by when increased unconjugated bilirubin is present in blood. Examples include hemolytic anemia, Gilbert syndrome, and Crigler-Najjar syndrome. Unconjugated bilirubin is lipid soluble, it is bound to albumin and cannot be excreted in urine. Conjugated or direct hyperbilirubinemia is occurred when increased conjugated bilirubin in blood due to impaired excretion from liver or biliary obstruction. Examples include viral hepatitis, biliary atresia, and gallstone obstruction. Conjugated bilirubin is water soluble. It is formed in the liver by UDP glucuronyl transferase excreted through bile, and it can appear in urine if blood levels are elevated. Conjugated hyperbilirubinemia is an increase in direct bilirubin in the blood due to impaired excretion of bilirubin from the liver into the bile ducts or obstruction of bile flow. Now, the causes of conjugated hyperbilirubinemia can be classified into four different groups: hepatocellular causes, cholestatic or intrahepatic causes, extrahepatic obstruction, and hereditary disorders. The first one is hepatocellular causes. Due to damage to hepatocyte, it impairs bilirubin excretion. Examples include viral hepatitis A, B, and C, alcoholic hepatitis, drug-induced liver injury, cirrhosis, autoimmune hepatitis, and sepsis. The second one is cholestatic causes. In this condition, impaired bile formation or secretion happens. Examples: primary biliary cholangitis, primary sclerosing cholangitis, pregnancy-associated cholestasis, and drug-induced cholestasis. Third, extrahepatic obstruction. Obstruction of bile ducts prevents bile flow. Examples, gallstones in common bile duct, carcinoma head of pancreas, cholangiocarcinoma, cholangiocarcinoma. Fourth is hereditary disorders. Dummett-Johnson syndrome. In this condition, defect in canalicular transport protein MRP2, conjugated bilirubin cannot be excreted efficiently and black-colored liver is observed. It is a benign condition. The second one we have Rotor syndrome, defect in hepatic storage and transport, no black liver is seen, and it is also a benign condition. Now I'll hand over to Jaya to continue with the topics.
I will start with the pathophysiology. Normally, unconjugated bilirubin leads to liver and Normally, unconjugated bilirubin enters the liver, gets conjugated and enters bile and reaches the intestine. In conjugated hyperbilirubinemia, bilirubin is conjugated normally, excretion into bile is impaired. Conjugated bilirubin leaks back into blood because it is water soluble, it appears in urine. This explains why patients often present with dark urine. Clinical features. The major clinical features includes jaundice, which causes yellow discoloration of the skin and sclera, dark urine due to bilirubinuria, pale or clay colored stools due to reduced tryptophan, uritis or itching caused by retention of bile salts, fatigue and malaise, loss of appetite, nausea and vomiting, right upper abdominal discomfort or pain. Among this, dark urine and pale stools are particularly helpful in distinguishing conjugated hyperbilirubinemia from the unconjugated hyperbilirubinemia. Now, signs on examination. Physical examination may reveal icterus, hepatomegaly, splenomegaly, scratch marks due to itching, right upper quadrant tenderness. Now, clinical triad. A classic triad often seen is jaundice plus dark urine plus pale stools. This combination strongly suggests cholestasis or biliary obstruction and should raise suspicion of conjugated hyperbilirubinemia. The next step after clinical evaluation is diagnosis and treatment. I now invite Japneet Kaur.
So now I will be discussing about laboratory findings. Total bilirubin is increased, direct bilirubin is increased, urine bilirubin is present, urine urobilinogen is decreased or absent in obstruction, ALP markedly increased, GGT increased, AST or ALT increased in hepatocellular diseases. So now I will be discussing about diagnostic tests. In blood tests, the total and direct bilirubin and liver function tests are done. In imaging, ultrasound of abdomen, CT scan, MRCP, ERCPs are done. In liver biopsy, liver biopsy is done when diagnosis remains uncertain. The complications include fat malabsorption, deficiency of vitamins A, D, E, and K, cholangitis, liver failure, and cirrhosis. Now, I will be discussing about management. Firstly, we will identify the underlying cause, then liver function tests and imaging, USG, MRCP, ERCP are done. Monitor bilirubin levels and functions, and then supportive care like hydration and nutrition are provided. The treatments include treating obstruction, antiviral therapy, stopping offending drugs, and surgery is done if obstruction is present. Preventions include vaccination against hepatitis B, safe blood transfusion and injection practices, avoiding excessive alcohol consumption, rational use of hepatotoxic drugs early diagnosis and treatment of gallstones and biliary diseases, maintain a healthy lifestyle and balanced diet. Now I will conclude the topic. Successful treatment of conjugated hyperbilirubinemia depends on early diagnosis and management of the underlying hepatobiliary disorder. Thank you and have a nice day.
Good morning, respected professors and my dear fellow batchmates. Myself Kaushiki Sen, and here I am with my friends Kaushani Shil, Khushnur Ahmed, Kea Ghatok and Kingshuk Haldar. Today we will discuss the topic Porphyriasis. So let's begin. So before discuss the topic Porphyriasis, we need to know what is heme and the heme synthesis pathway. So what is heme? Heme is the molecule of life, and heme is an essential iron-containing porphyrin compound. It is composed of protoporphyrin 9 and a ferrous iron. Heme is a prosthetic group, means a non-protein part in hemoglobin, myoglobin and cytochromes. So here is the structure of the heme. These are the 4 chiral rings containing in the heme, and this is the protoporphyrin ring. Here is the ferrous iron. This is the main, here the oxygen bounds for red blood cell. There are several functions of heme in our body. It helps in oxygen transport, cellular respiration, enzyme activity. So heme is an essential cofactor for cytochrome P450 enzymes. This is the heme synthesis pathway. Succinyl-CoA with the help of succinyl-CoA condenses with glycine with the help of enzyme synthase and forms delta aminolevulinic acid. Delta aminolevulinic acid in the presence of aldehydatase forms porphobilinogen. Porphobilinogen with the help of enzyme porphobilinogen deaminase forms hydroxymethylbilane. Hydroxymethylbilane in presence of uroporphyrinogen 3 synthase forms uroporphyrinogen 3. And the next step, uroporphyrinogen 3 under the influence of uroporphyrinogen decarboxylase forms coproporphyrinogen 3. And then the coproporphyrinogen 3 under the influence of coproporphyrinogen oxidase forms protoporphyrinogen 9. Then the protoporphyrinogen 9 with the help of enzyme protoporphyrinogen oxidase forms protoporphyrin 9, and here the ferrous ion is inserted in the protoporphyrin 9 with the help of enzyme ferrochelatase and forms the main compound heme. So this is the total heme synthesis pathway, and now I will hand over the next topic to Khushnur Ahmed.
So before diving into the topic porphyria, we should know what porphyria is. Porphyria are inborn errors of metabolism caused by inherited deficiencies of enzymes involved in heme synthesis. This leads to the accumulation of porphyria and their precursors in the body, resulting in neurological symptoms, abdominal pain, and photosensitivity. Porphyria is classified into 2 types: inherited and acquired. Inherited is further classified divided into 2 types: hepatic porphyria and erythropoietic porphyria. Now, acquired porphyria is very rare, and it is of 4 types: renal failure, liver disease, tumors, and toxic metals. Inherited porphyria. Inherited porphyria is again of 2 types: hepatic porphyria and erythropoietic porphyria. Hepatic porphyria is subclassified into 4 categories: acute intermittent porphyria, Porphyria cutanea Tarda, hereditary porphyria, and variegate porphyria. Erythropoietic porphyria is again of 2 types: congenital erythropoietic porphyria, protoporphyria. Now, Kingshuk Haldar will be continuing from him.
So good morning everyone. Now I am going to discuss about hepatic porphyria within the context of inherited porphyria. The first one is acute intermittent porphyria. It is due to an enzyme defect, uroporphyrinogen 1 synthase, also known as HMB synthase or PBG deaminase. Affected individual will show abdominal pain, vomiting, and along with peripheral neuropathy, seizures, etc. And on lab diagnosis, we can see that affected individual will have elevated PBG or ALA in urine, and and known photosensitivity in this kind of porphyria we'll see. Then the next type is Porphyria, Cutanea, Tarda. It is the most common porphyria among all the porphyrias, and affected individual will have blisters on exposed under the sunlight. So next two porphyrias will be discussed by Kea.
Hello, myself Kea Godok, roll number 57. So I'll start with the next hereditary coproporphyria, which is come in the under of hepatic porphyria with the enzyme defect of coproporphyrinogen oxidase, which is a mitochondrial enzyme lead to the accumulation of corpoporphyrinogen 3 in the body. Clinical features are like neurovascular and skin symptom, which include severe abdomen pain with nausea and constipation, peripheral neuropathy, anxiety, tachycardia, and photosensitivity result in skin lesions. This picture here showing that what looks like in case of hereditary coproporphyria. Next, variegated porphyria with the enzyme defect of protoporphyrinogen oxidase, which lead to the accumulation of protoporphyrinogen oxidase 9 in the body. Clinical features are like abdomen pain, neuropsychiatric symptom, and photosensitivity, which is kind of similar like in the case of hereditary coproporphyria. But only one key distinction here is that the photosensitivity and the resultant skin lesions are generally more prominent in this case than in the hereditary coproporphyria. So what is this picture showing that what variegated porphyria look like? So next topic will be start by my.
Good morning, everyone. I'm Glycogenesis, roll number 16. I shall continue from here. So the topic is erythropoietic inherited porphyria, and as it is already mentioned in the previous slides, that it is of two types. So the first one is congenital erythropoietic porphyria. This is an exception because usually the inherited porphyrias are autosomal dominant, but this is autosomal recessive. It is caused due to the enzyme defect in the enzyme uroporphyrinogen 3 co-synthase. So therefore, hydroxymethylbilin is not converted into uroporphyrinogen 3, and thus it gets accumulated. And the pathogenesis is that this accumulated porphyrins, under the influence of this UV light, when they are exposed, they lead to the formation of the reactive oxygen species, which causes lysosomal damage, and it causes release of enzymes, which leads to the skin lesions. Now, the clinical features, it includes extreme photosensitivity, sunlight causes severe and painful blistering and skin damage, often leading to severe facial scarring and deformity over time. Then there is also erythrodontia, which is a reddish brown discoloration of the teeth, and it is also fluorescent under UV light. The urine that is passed, it is also dark and it is quite reddish or purplish. Now, because of this, all of these clinical interpretations, it is also known as a vampire's disease. Because according to people, it is believed that the mythical creatures, the vampires, they also believed to have such red teeth and a whole lot of scars on their faces. And of course, they were extremely photosensitive. The next one is erythropoietic protoporphyria. The erythropoietic protoporphyria is caused due to the defect in the enzyme ferrochelatase, and therefore, from the protoporphyrin 9, Heme is not formed, and protoporphyrin 9 gets accumulated. The clinical features, it includes immediate sun reactions like burning, itching, stinging pain, redness, and immediate swelling upon sun exposure. But the key distinction of the erythropoietic protoporphyria from Porphyria cutanea tarda or the congenital erythropoietic porphyria is that in this case there is no blistering, means not no blistering, but there is no such significant blistering. So it also includes certain systemic complications, like it might include liver involvement. There might be liver damage because of the excess accumulation of the protoporphyrin. Then the treatments and the management. For the treatment, we have afamelanotide, which is placing an implant under the skin that increases the melanin production to act as an internal sunscreen, allowing more time in the sun without painful reactions. Supplements like high doses of beta carotene and medications like hydroxychloroquine to help absorb the excess of the porphyrins. Thank you.
accumulation of porphyrin, and that's why these symptoms. Mechanisms.